Dr. Ted Venema Talks Audiology, the educational whiteboard series brought to you by Next Gen Hearing.
Hi, I'm Ted Venema, here to talk to you today about Meniere's disease. Meniere's, a relatively less known cause of sensorineural hearing loss. Not at all as prevalent as noise-induced hearing loss or presbycusis. About 1 to 200 people in 100,000 tend to come up with symptoms of Meniere's disease. That roughly corresponds to about 0.15% of the population having some form of Meniere's disease. Meniere's disease, these symptoms can be most unpleasant, and it might be practical or advisable to say you wouldn't want to wish it on your worst enemy, because the symptoms can be horrible. Some people elect for a complete labyrinth ectomy of the ear in order to get rid of it, because it's most unpleasant. People develop Meniere's, they tend to develop it in adulthood. Increasing incidence or prevalence of it is toward age 60. So toward middle age, people begin to develop Meniere's disease if they're going to get it. It's named after a physician, Prosper Meniere, a French physician, who I'm told was the first to really make the connection between vertigo and the inner ear in the 1800s. Figure 1 shows you endolymphatic hydrops, or where it comes from. It's actually a cross-section of the cochlea in that particular figure. And you'll notice in there the chambers within the cochlea, the scala vestibuli, the scala media, the triangular shape in between, and then below the scala tympani. Each coil of the cochlea having the scala vestibuli, scala media, and scala tympani. Well, the hair cells of the cochlea are located in the scala media. And let's talk about the fluids in the cochlea, because this is a hydrops we're talking about here. The scala vestibuli and scala tympani are part of what they call the bony labyrinth of the cochlea. They contain a fluid called perilymph, which is quite close in chemical composition to cerebrospinal fluid. High in sodium, low in potassium. In the scala media, however, the chemical composition of the fluid is the opposite. It's called endolymph. Endolymph is the fluid inside the scala media, and it is low in sodium, high in potassium. This is significant because opposite chemical composition fluids tend to create an electrical charge, and that's exactly what the cochlea does. It serves almost like a battery. It transduces or changes hydraulic fluid motion into electrical current, and electricity, of course, is the language the brain understands. So what are the causes of too much endolymph in the scala media? Because that is what gives rise to Meniere's disease. The causes, well, too much stria vascularis secretion of endolymph fluid. The stria vascularis, if you look on that diagram carefully, it's this blackened area or dark area right near the spiral ligament on the outer rings of the cochlea. So the stria vascularis spans the entire length of the cochlea along all the coils within the scala media. And it tends to be the tropic nourishment function, supplying oxygen, food supply to those hungry little hair cells, because they are little demanding divas. They want it all, and they want it now. There might be too much secretion by the stria vascularis of endolymph, because that's what produces endolymph. But also some theorize that maybe there's too little endolymphatic sac absorption of the endolymph. Either way, you end up with too much endolymph in the scala media of the cochlea, causing a bulge, too much. Those who indulge, bulge, my mother would say. An autoimmune disorder of some type, some theorize Meniere's to be. We really don't know the cause of it. And we just don't have a good handle on that yet. The symptoms of classic Meniere's are 3. First, rotary vertigo. Secondly, roaring tinnitus as opposed to high-pitch ringing tinnitus associated with noise-induced loss. This is roaring tinnitus, like a and a rising or reverse sensory neural hearing loss. Normally, sensory neural hearing loss tends to drop in the highs. Better hearing for the bass, poorer hearing for the highs. Meniere's is just the opposite. It tends to be worse in the lows and better in the highs. Hence, we call it a reverse hearing loss. It should be stipulated or said here too that the symptoms of Meniere's are episodic. The person sometimes can almost feel the aura of the symptoms beginning to appear, much the way someone with epilepsy can feel the aura of a seizure coming. The person can tell the symptoms are coming. They may last for an hour to several hours, God knows, but they are most unpleasant. 80% of times that the Meniere's occurs in one ear, in ein Ohr. But if it happens to hit both ears, the second ear tends to become affected within 2 years after the first ear has become affected by it. But thank goodness most of it is unilateral. At any rate, here's something to consider in the box. All Meniere's is endolymphatic eye drops, but not all endolymphatic eye drops is Meniere's. Sometimes not all of these classic symptoms occur with the same severity and regularity. Sometimes the Meniere's is more confined to the vestibular system, resulting in an unpleasant share of rotary vertigo, but not necessarily the concomitant hearing loss that would go with it. So it's not just a neat, tight little box. But suffice to say, all Meniere's is endolymphatic eye drops, but not all endolymphatic eye drops is Meniere's. Now let's take our attention to something really interesting here as well. Figure 2. Figure 2 shows the typical audiogram associated with Meniere's. You can see the right ear is showing normal hearing, and the left ear is showing that rising or reverse sensory neural hearing loss. Now, I've laid across the top of that figure a band stretching across the top of the audiogram. That band represents the floor of the hair cells, the basilar membrane, the floor in the scala media upon which the hair cells all stand. Now that floor, notice how it's narrow at one end and wider at the other end. This is significant because it explains two things, but look again closely. The wide end of the basilar membrane is actually at the base, at the apex, the skinny apex of the cochlea where the low frequencies are. And the narrow end of hair cell region, the scala media is actually narrowest at the wide end of the cochlea. So this is just backwards from what one would think. And that is significant for two reasons. One reason is that it explains why high-frequency sounds stimulate hair cells at the fat base of the cochlea, and it explains why low-frequency sounds stimulate the narrow apex of the cochlea. It's all about mass and stiffness. Low frequencies vibrate mass. They resonate with mass. If you're sitting in your apartment and the people upstairs are playing loud music, what comes through your ceiling? The thump of the bass guitar and the drum beat. Stiffness resonates with high frequencies. So if there's a stiff spring sticking out of the wall, it's hard for me to move that back and forth slowly, but it's easy for me to jiggle it quickly. So highs resonate with stiffness, lows resonate with mass. So now the basilar membrane, the floor of the scala media, it's widest at the narrow apex of the cochlea. It has most mass, and therefore it resonates with low frequency sounds. The high frequency fat end of the cochlea actually has the narrowest basilar membrane width, and it's most stiff. And it's these physical properties that explain why the cochlea is tonotopic, why highs stimulate the wide base, and why lows stimulate the apex. Please don't think it's because low frequencies have long sound waves, and so therefore they make a longer traveling wave, because, hey, a 250 hertz tone, middle C, is 4.5 feet long. The cochlea, if you unroll it, is about 3 centimeters long. So we're comparing apples and oranges there. Always realize mass and stiffness properties. Now back to Meniere's. If you've got endolymphatic hydrops, you will tend to bulge the less stiff area of the scala media, the widest end of the scala media, which is at the narrow, low-frequency apex of the cochlea. You can see this difference in size of the scala media both in figure 2, as I've just unrolled the cochlea and laid the basilar membrane on top of the audiogram, but you can also see this in figure 1, the cross-section of the cochlea. And you'll note that I took pains to draw the scala media getting longer and longer as you get toward the narrow apex of the cochlea. Meniere's disease results in a low-frequency audiogram because the endolymphatic hydrops, the excess endolymph, is more apt to bulge the walls of the scala media where those walls are least stiff. And that's also where they have most mass, and that is at the narrow apex of the cochlea, thus explaining why Meniere's tends to be a low-frequency hearing loss. Now, with repeated episodes, the person is left with increasing degrees of permanent low-frequency sensory neural loss. So after repeated bouts of Meniere's, that low-frequency loss tends to spread into the mid and higher frequencies. So each bout or episode of Meniere's tends to leave you with a bit of residual sensory neural hearing loss that gradually gets worse over time with repeated episodes. At any rate, treatment for Meniere's is everything from oral steroids to a complete removal of the cochlea and vestibular systems, labyrinthectomy. Oral steroids with a low sodium or low salt diet is the most common first treatment for Meniere's, and it's because we believe it could be an autoimmune disorder. So if the steroids tend to alleviate it, that shows how it probably is an autoimmune disorder. Low salt diet to decrease pressure. You want the body to act more in a diuretic fashion so that you're releasing excess fluids, therefore reducing the likelihood of too much endolymph. Some people go for an endolymphatic shunt, a way of making sure that excess endolymph pressure is no more. Some actually advise an injection or a seepage of gentamicin, which is the antibiotic known to be ototoxic. It's one of those aminoglycosides that ending in mycin, known to be ototoxic. And they put that so that through a transtympanic membrane approach, and they let that sit against the round window of the cochlea, thus seeping into the scala tympani. And that is hoped will kill off the vestibular section or area of that ear, but not the cochlear hair cell region. So by that gentamicin approach, it's hoped that you can alleviate the symptoms of vertigo and Meniere's without causing ototoxicity to cochlear hair cells. So that's always, the person is advised to go for regular routine hearing tests to monitor the course of possible cochlear hair cell damage when someone's getting the gentamicin seepage type of treatment. Another type is called a vestibular neurectomy. This is a way of snipping or sectioning the eighth nerve, but the vestibular branch of the eighth nerve, not the cochlear branch. It's difficult to access that particular portion of the eighth nerve, however, so the surgery is rather delicate and time-consuming. But that is one approach that's known to have pretty good results. Some people just elect for a complete labyrinthectomy if all comes to bad and the symptoms are absolutely unbearable. At any rate, on that little pleasant note, it has been my pleasure to talk to you today about Meniere's disease. Here's hoping it was somewhat helpful. Cheers.